Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. This is a 3-part panel series exploring FND across the international arena. Part 1 includes FND diagnosis, access, and discussion of treatment landscapes. Part 2 includes FND culturally relevant factors within the biopsychosocial spiritual model, and Part 3 covers FND research, funding, and international collaborations. My gracious guests include Dr. Lucia Tesolin, currently in Peru, but with prior experience in Italy, Great Britain, and Switzerland. Dr. Sonja Rutten from the University of Amsterdam, the Netherlands, providing input on the Dutch and FND. Dr. Takamichi Kanbayashi from Tokyo, presently learning FND in Edinburg, the UK. Dr. Lucas de Andreas at the University of São Paulo, Brazil. Dr. Chrisma Pretorius at Stellenbosch University in South Africa, and Dr. Sanjay Pandey, presently in Delhi, India. As a host, these conversations felt like a window into the world of FND across the international landscape, seeing what FND education, practice, care, and research is really like day to day in these different regions. I found these speakers, their work, and their perspectives to be so thoughtful, commendable, and inspiring, and also a clear highlight of just how much work there is to be done in FND across the world. I hope you enjoyed this series as much as I did. Oh, well, I'm so thrilled to have everyone here again. It's such a delight and so wonderful and shows such commitment that each of you would join again for our podcast series here to talk about multicultural aspects in FND, which I know our listeners are really eager to hear about. As we kind of talked in our prep meeting here, that today we're hoping to cover FND cultural factors and existing biopsychosocial models and possible adaptations that might be relevant for different countries and cultures. And then if there's time, hopefully also approaching FND international collaboration, both clinical and research. And like last time, we're going to continue to go through hearing from each country and their representative and what we can take away from lessons, knowledge, future steps, and sort of hopes and dreams, I think. So I'm really looking forward to hearing from everyone. And as we said, kind of our first up on the list to hear about cultural specific factors is Lucia from Peru.
Yes, hi everybody. So I will rapidly go through each class of factors. I will delay a little bit more than 5 minutes because they are a lot. But as predisposing factor, my clinical experience in Peru has confirmed the role of some factors known as female sex and of others. For example, I would like to highlight that in Peru, childhood epilepsy is very common due to both factors, etiology, because in some areas of Amazonas, it's very frequent to have encephalitis, neurocysticercosis, and of brain malformation etiology. And considering that only a small part of the population participates also in pregnant prevention program, and abortion is not allowed. So neither in case of fetal malformation or genetic disease. So all this leads to a high number of children with epilepsy and developmental delays that, as we know, are predisposing factor of dissociative seizure. Furthermore, other predisposing factors of FND like autism or ADHD that are also related to environmental factors as dysfunctional families, alcohol abuse in the family, low education are really frequent. Concerning other predisposing factors, it is known that physical and sexual abuse is very common in Latin America, and this is often misunderstood by the family members and left psychologically untreated for all life of the victim. And the majority of Peruvians is exposed to street criminalities, lack of job guarantees, or medical assistance. That means financial strain and interpersonal challenges that are other predisposing factors. And moreover, for cultural reason, and this is something more particular of Peru, I have noted that alexithymia is quite common because the Peruvian population is not used to complain openly, to express openly disappointment, anger, fear to family or friends. That's because the Inca culture, because due to Inca culture, one must accept his life and accept it in an attitude towards life and towards problem that is always positive. So this tendency to limit the expression of a negative emotion seems seemed like unhelpful. Sometimes leads to the belief that emotion doesn't require medical assistance. So psychiatrists are considered as to treat just crazy people, and psychologists that address past traumas, but in vain. And in fact, in Inca culture, over the centuries, the curanderos have been the therapists responsible for treating psychosomatic disorders, because using ayahuasca session, they allow the patient to open a window to their emotion, and they accompany the patient in the journey. That lasts just few days. So it's like a journey really inside. And on the basis of this tradition, I sometimes feel like Peruvians accept this diffuse disorganization, lack of social assistance as seen inevitable. And they don't seem to consider it necessary to process the emotions and the effect of this resignation on his body or her body. And furthermore, they cannot afford a psychological session, and the public health system offers just 5 sessions each one, with very long waiting list. And if the patient, yes,
5 sessions only.
5 sessions, only 5 sessions.
Goodness.
Yes. And if the patient misses one session, it cancels all the program. So they can't, and imagine sometimes they live very far away, they can't access, they arrive late, so they lose everything. So that's really a point. As a triggering factors, as already told the last time, Peru and many other Latin American country is not providing some guarantees, some security for the future. And so, of course, it exposes people to permanent employment status, no retirement pension, no insurance for disease, and there is no law that guarantees a reduction of working hours or redistribution of tasks in case of residual disability. So if you are discapacitated, if you have a disability, you just receive a discapacitated pension that is really, really low, and you can't live with it. So this is another point. And regarding the maintenance factor, lack of diagnostic agreement is the stronger one. I would like to emphasize, as I mentioned the last time, that the doctors in Peru still use ICD-10. So patients with FND are often diagnosed as conversion disorder or anxiety depression syndrome and are referred to psychiatrists, rarely psychologists, and never rehabilitation therapy. And usually the neurologist says there is no neurological disease, diagnosis, and the problem is anxiety or stress. They don't explain what is FND. And in general, the patients do not have the right to receive any medical report. So it is written in the computer of the hospital, but they don't receive nothing. So it's clear that patient information is absolutely not existent. And moreover, from my experience, the average of cultural level is obviously lower than Europe and USA. So the material on FND, even if in Spanish, sometimes is not easy to understand, despite being available. There is also another cultural factor, the lack of prevention habit. Obviously, we know that FND has this recurrence attitude and characteristics. And these attitudes stem from the fact that the patient prioritizes survival needs to well-being or being able to work. So often patients with FND show up for the first time with FND as a symptom triggered by pain, accident, family conflict. And when they are told everything is negative, they recover. And then they don't care, they don't bother about the diagnosis, and they represent other times. So that run the risk of chronicity. So in summary, compared to Europe or USA, in order to influence the prognosis of FND in Latin America, we have to invest more in education of the patients. We've adapted to their specific needs, and as well, of course, as training for a healthcare professional. And finally, I think that we have give them a therapy offer that is adapted to their needs. For example, few sessions, because they are not keen on participating in many sessions. So a short offer with flexible times, because sometimes due to the traffic, due to the general disorganization, they don't come, they come late, they don't answer to the phone, and with the possibility of rescheduling. And I think also online session, because that will be a good point, not for physiotherapy, but just a follow-up online. That could be a great option.
What a wealth of information, Lucia. That was such a useful summary. And I didn't even consider factors like early access to healthcare and perinatal care, essentially, as an FND risk factor that might be more prevalent in certain countries rather than others, which just shows my lack of imagination of the ways in which FND and cultural factors can interact.
I think I'm lucky, because being European, I can have another vision here, no? Because maybe they don't realize some factor, but being a stranger, I can see it clearly.
Yeah, that's one. It's so great that you are spreading that awareness, right? Because I think these are really very impactful aspects that do significantly contribute to FND prevalence that really just aren't talked about, at least, or thought about. At least I haven't come across it in a lot of literature and a lot of research, or in a lot of our training around FND. So that's such a wonderful thing to start to bring to everyone's attention. Thank you. Next up, we are going to hear from Sonja from the Netherlands, and how FND factors might be, although I think we've had a lovely dinner conversation about this too, where I'm like, oh, this is so different. So very excited to hear from Sonja as well about FND in the Netherlands.
Yeah, thank you so much for having me, Erica. Lucia just gave a beautiful overview of how all these different risk factors contribute to the prevalence of FND in Peru. And I think that in that aspect, I live in a country that is very comparable to what is described in most of the publications on FND, because most of the FND leading experts come from a Western country. So I think that I can't give a beautiful description like Lucia just did, but I do think that there are some things that are specific to the Netherlands that are relevant for FND, that are embedded in our culture. So I thought it might be nice to discuss those. So first of all, in our last meeting, I discussed how our healthcare system is actually pretty good, especially when you compare it to the situation of other speakers here. And I think that the general Dutch population does have an idea about how the body works. The biopsychosocial model is known to all physicians, so we tend to have a broader view on physical and mental complaints. We do still have a dualistic view, separating body and mind, that is very embedded in our views on health and illness. And I think that is particularly unhelpful when it comes to FND. But you see that the younger generation does realize that you can't separate the two, and you have to pay attention to both your mental well-being and your physical well-being in order to stay in good shape. I think when it comes to healthcare, the Dutch tend to seek help with a physician when they start developing new symptoms. So spirituality and religion is less of a thing in the Netherlands. I think that half of the Dutch population is actually atheist or agnostic. So religion is not a place where many people seek their resort when it comes to illness or other problems they encounter in life. And I also think that the Dutch are unique in their assertiveness and directness, and also their a reluctancy to take medication, which is actually quite helpful when it comes to FND. So as a doctor in the Netherlands, you see that many of the patients come in and actually have an idea about what might be going on. They did their research, and they often have a very clear question regarding diagnostics or treatment. And we live in a very flat country, and that's not just literally speaking, that's also figuratively speaking. So you see that the people that come into your office are not very sensitive to hierarchy, and they can be quite demanding and assertive when they want something. And I actually quite like that, because you get difficult questions and it keeps you on your toes. But sometimes it can be difficult, for example, when there is doubt about the diagnosis of FND. You would really have to properly explain why other diagnoses are less likely, or why certain tests might not be relevant, why certain treatments are not preferred. So, well, that is always a challenge, but that's what makes the work with this patient group extra interesting, I think. And what I just mentioned, the Dutch really don't like medications. And that is very nice when it comes to FND, because there are no medications for FND. But I think that's a huge difference with a lot of other countries where people tend to seek medication as treatment for whatever illness they have. And I think that's because we have this history of a strong Calvinistic culture. We like to solve our own problems, work hard, don't complain. But it also makes it more difficult for people who have symptoms that are hard to understand, like in the case of FND. People do tend to think that if you just work hard, you can fix everything, and you just have to, put in some extra effort. And we know that in the case of FND, an extra focus on symptoms and trying harder is actually counterproductive. So that needs a lot of explaining, I think, when you see a Dutch patient. Another thing is that if the regular treatments for FND fail, people do tend to seek help elsewhere. They don't tend to just accept and resign and just think, well, this is what it is, but they try and look for other ways to get better, which I completely understand. But that can result in seeking sometimes very costly, sometimes dangerous alternative types of treatment, which can be a concern at times. I think that these are the most interesting aspects when it comes to the situation in the Netherlands. Overall, I think the social facilities and healthcare in the Netherlands are a lot better than in some of the countries that the other speakers reside in, so we can't complain. But there's still a lot of work we have to do over here as well when it comes to improving diagnosis, getting more treatment options, more treatment facilities. So there's stuff to do for us as well. But overall, we're in good shape, I think.
Yeah, I have to share a funny anecdote. It's when we were at FNDS and Sonja had reviewed one of the workbooks that we use here in the US. And she made the comment, Sonja, if you don't mind me sharing, about the language was just so nice. We'd have to change some of that because it's, they don't like the fluffiness of it, just more direct. Just tell them what to do. I was like, oh, that would sound like, here would be like a too blunt or demanding or just, like commanding someone. She's like, no, just
tell us what to do and we'll do it. Yeah, exactly. We don't like a lot of pleasantries and niceties. We just want to get going and get to work. So that's definitely a huge difference. Yeah.
I love that. And, ironically, I didn't particularly envision, myself or the workbook that we were using and kind of developing as overly nice. That wasn't our intent. But I was like, oh, wow, it could be perceived as that. But I can absolutely see it. It was not direct. It was not just do this. No. You are very nice for Dutch standards, extremely nice. And I also noticed last time when we were making this podcast that everybody after the introduction spent quite some time thanking you for the opportunity to speak at this podcast. And I was the only one who just went into it and just started talking about what we needed to discuss. And afterwards I was like, oh, this is the Dutch rudeness again. I'm so sorry, but that's just the way we are. It's
just
not
get to
rude.
Work.
Yeah, it's not rude. It's just it's interesting. It's very singular focus, but very polite. It's polite, respectful, but focused. It's great. Oh, I love it. That's wonderful. Well, thank you, Sonja. It's been wonderful to hear from you always. And hopefully we can develop more collaborations as well going forward.
Thanks.
Next, we have Takamichi, who's going to speak about FND factors that might be present in Japan based on his experience.
Thank you for asking, Erika. I'm very honored to join this podcast recording again. Thank you very much. And so sorry, my comment might be bleak, but anyway, so at first, regarding the prevalence of various FND symptoms, in my experience, I feel that there is no significant difference in Japan, and also, there is no significant difference in gender. I feel FND tends to be more commonly seen in female women. So, but we don't have. In Japan, we don't have official epidemiological data on FND. So this is one of the challenges for our future research. Yeah. And so in terms of stigma in Japan, I feel that there is still a strong cultural bias where FND patients are perceived as like deliberately producing their symptoms, like malingering, or just being lazy. So because of this, I think some FND patients hesitate to visit the doctor or struggle to gain understanding from people around them. And so to improve this situation, we needed to spread accurate knowledge and information about the FND, not only healthcare provider, but also to general public, I think. So apart from that, in Japan, there is also the issue of lack of specialists especially in rural areas. So it may be the same situation in other countries as well. But so to address this situation, online consultation and follow-ups might be helpful. But however, unfortunately, the infrastructure to provide these services is still not fully established in Japan. And so regarding how to adapt biopsychosocial models for FND patients, we needed to build a system that enables integrated therapy for patients with FND. For example, in Japan, there still seems to be a bit of a barrier between neurology and psychiatry, I think. So I think it is necessary to create opportunities for different medical specialists to engage in discussions. Yeah, that's my comment. Thank you.
Thank you, Takamichi. Yeah, I think rural access is almost a transnational issue, especially, I know here in the US, it's very, very similar where rural access is so extremely limited, where we often have people traveling hours or even coming and staying overnight to stay in the city to see a specialist, or spending large amounts of money to come and receive treatment for a period of time in the city. But that requires a hotel stay, and that staying in a hotel for a month or 3 weeks is expensive, and really only, a luxury that can be afforded to people who have the financial means. And a lot of individuals in rural communities don't have those same means or have the same someone who can drive them and stay with them, right? So someone who can take off work for that long, like a family member. So it is a very big access issue. Stigma aside, stigma and seeking care aside. Yeah, it's an important one to highlight. And I think probably a lot of individuals think of Japan as, a technologically advanced hub, and, just think of Tokyo and just kind of have maybe an unrealistic sort of impression, when really, there's
in our area, medical system and the number of doctors, good. It's very sophisticated. But rural area is one of the problems in our country. Yeah,
exactly. And it's not just they're just because a city is or a country has major industrialized cities that are, leaders in multiple facets, doesn't mean that rural areas still are not rural areas that don't have the same access, which is something to always keep in mind. Yeah, that's a great point. Thank you. Next, we have Lucas from Brazil to hear from. If Lucas is... Thanks, Lucas.
Thank you for inviting me. Well, first, Sonja, compared to Dutch people, Brazilians usually look for miracle cure or medication to treat FND. Very frustrated with the lack of medications for these disorders here in Brazil. So it's interesting what you said about Dutch people. They don't mind to not get any medication.
We actually don't like to take aspirin when we have a headache. It's that bad. Like, we don't want any medications.
That is so impressive.
Well, regarding the cultural factors, unfortunately, here in Brazil, significant portion of the population is exposed to unfavorable social economic. So this segment of the population is often highly exposed to risk factors associated with the appearance of FND. So we have a lot of parental neglect, sexual and moral abuse during childhood, exposure to trauma, and vulnerability within the healthcare system. So our patients mainly use the public health system to get their treatment. And that's an issue here in Brazil. It's very hard to have access to care system in the public service. And in epidemiology, here we have mainly women as well. So around 75 to 76% of FND patients diagnosis in Brazil are women. I believe that here in Brazil, they are more exposed to trauma, sexual and moral abuse, and vulnerabilities in every way. I think we have a very, I don't know the words to say, but the women are, how do I say, when they are not a minority group, but they are treated many ways inferior to men here in Brazil. So this is terrible thing to realize, and I think that help more common as well. And in our service, the treatment is almost focused on serving the public healthcare system. So very rare cases involving supplementary health coverage. And this is a challenge because when we try to refer these patients to primary or secondary healthcare centers, since we are a tertiary healthcare center, we have several reasons that make it difficult. First one is we have a lack of knowledge and understanding of how to manage this type of condition from the healthcare professionals, and usually they mistreat these patients and neglect the treatment because it's a common belief that they are creating their symptoms. So it is very usual or common that these patients in most of our public health centers, they are mistreated and sometimes they suffer moral abuse from the health professionals. And second, which I think is very important as well, is many of these cases involve severe psychosocial situations, such as living with an abuser, financial hardship, lack of access to healthcare systems, and lack of access to basic education. And so I think, in short, those problems that, in my view, make this clinical condition particularly challenging to address in Brazil.
Lucas, I really appreciate that honest perception, right, of issues facing people with FND in Brazil, and especially acknowledging that there are gender differences in society that likely do contribute to prevalence. And I think that would be such an interesting and necessary and sobering aspect to consider FND prevalence rates possibly linked to gender equality or gender views, not just between men and women, but also individuals who identify in more gender diverse ways, et cetera. But I appreciate your honesty about that. I think it's really important for our listeners to know that not in every country are women treated as equal or regarded in that way, and then that can have serious repercussions. And also highlighting that, similar to what Takamichi had reported, that in all countries, that FND is not regarded as a legitimate quote unquote illness, and that malingering, I guess I'm, again, very privileged here in the U.S. where we kind of don't think of, at least I hope some of my colleagues still probably do regard it as malingering, they're just faking. But I don't think that's the common view, or not really put on the table at all, especially in anyone who's really worked with FND or even familiar with it. And I don't think even my colleagues less familiar would say they're faking. They'd be like, well, something's going on. I don't know what it is. It's beyond, I'm not educated in it, but no, they're not faking, they're not malingering.
Yeah.
And it's just, I think it's really sobering to hear, as well as necessary to hear, that still in large parts of the world, this is still regarded as a volitional illness or a faked illness or something done deliberately. And I think that's really important to highlight and acknowledge. So thank you, Lucas. That was a really, really powerful and great summary. Next up, we have Chrisma from South Africa.
Thank you, Erica, for having me. I'm going to start off by giving a contrast to what Sonja has reported, because the first thing I need to highlight in South Africa is spiritual and traditional beliefs, which play a very important part. In South Africa, particularly in rural areas, many individuals may attribute physical or neurological symptoms to supernatural forces or ancestral spirits, for example. This include beliefs in witchcraft, curses, or spiritual attacks, which can result in seeking treatment from traditional healers or spiritual healers or leaders rather than medical professionals. And that is very common in South Africa. And another thing is that traditional South African cultures often adopt a holistic understanding of health where mind, body, and spirit are interlinked. So for individuals with FND, this could mean that the disorder might be seen not just as neurological or psychological, but as a spiritual imbalance, for example. And in a biopsychosocial spiritual model, this need to be addressed and incorporated and considered. Another important factor is that South Africa has 11 official languages, and healthcare providers may not always be fluent in the language of the patient. So the language barrier can create misunderstandings and difficulties in discussing symptoms or psychological components of FND. So this is where the role of translators would come in, but that in itself can be problematic as well. What is translated? How is it translated? And all of that. Then one can't talk about South Africa without mentioning the history of apartheid that has left deep psychological scars, socioeconomic inequalities, historical trauma, and ongoing struggles related to racism and identity can contribute to the psychological stress that may exacerbate or trigger FND symptoms. And the emotional burden from this historical trauma, particularly among marginalized communities, should be considered when understanding how FND presents in the population. Then it just as a side note, gender-based violence, for example, is some of the prevalence of that is some of the highest in the world in South Africa. So that's another factor that we should consider. There's just 2 points about healthcare access. Some of it has been said already. So here we have this traditional healers versus the medical professionals. So many South Africans may turn to traditional healers first. And there's often a significant cultural divide between traditional and Western healthcare practices, with some individuals preferring the former due to trust in cultural practices and past experiences. So that's why they prefer that. And then the health inequality that some people have spoken about, it's very similar and prevalent in South Africa as well. And then finally, mental health issues are often stigmatized in many South African communities, especially in more rural communities. And this can lead to delayed diagnosis or reluctance to seek help, particularly in a healthcare system where mental health services might not be readily accessible. If I think about the adapting the biopsychosocial model to incorporate or to what should we do, we need to incorporate cultural sensitivity, and community involvement is important, and an understanding of traditional healing practices would be crucial in providing effective care for individuals with FND. And it's important for healthcare providers to engage with both patients and their families, respecting their cultural perspectives while also delivering evidence-based treatments, which is sometimes a tricky thing to do. And that's some of the cultural factors that play a role in South Africa.
That's really helpful, Chrisma. And, highlighting, I didn't really think about language, right? As South Africa being such a diverse place when it comes to language. But now that you bring it up, of course, given its complex history with multiple European nations, as well as more indigenous language factors and cultural factors, that it really is more of a melting pot area, and that does increase challenges for care, right? In a condition where we're working to make sure we have enough resources and education to go around, let alone translate that and interpret that and And I'm wondering if you've noticed, in addition to just very helpful acknowledgement of the cultural history present in South Africa, right? And that's very marked. I'm wondering, from your perception, are there any more regional or subcultural specific factors where, based on that melting pot, if certain aspects of the population are more or less welcoming or open to FND, psychological factors, medication preferences, or if it tends to be more unified, where, the whole region of South Africa, even if speaking different languages and having different cultural elements, and cultural experiences, approaches FND in a similar way, or if it's more cultural specific?
No, thank you for that question, Erica. No, it's definitely more cultural specific, and it will even vary between regions and different groups of people. So there's definitely not a unified approach there. So we have a lot of work to do to try and work towards a unified approach. But I don't know if we'll ever get there. I think it's more of an integrated approach where there's consideration for all these different perspectives and where we try to help people in the best way possible.
Yeah, so it sounds like using a biopsychosocial model that allows for that individual adaptation is even more important in a region where there are so many different diverse cultural, language, historical factors. Yeah.
Absolutely.
Yeah.
Yes.
Great. Thank you, Chrisma. Last but not least, we have Sanjay to share cultural perspectives about FND in India. And as I recall, we've also had several nice dinner conversations about this where I'm always just left. And actually, I want to give Sanjay credit for actually suggesting the multicultural podcast. This is all Sanjay's brainchild out of a dinner conversation in which we were just chatting about those different factors. You should really do the podcast on this. So everyone thanks Sanjay for his great idea and encouragement and willingness. So really looking forward to our listeners being able to hear your perspective, as well as thank you from our listeners for the idea of bringing this information out to the world.
Thanks, Erica. I was just listening to the inputs from other speakers, and our system is quite huge, because if you see the population of India, it is, I think, most populous country, maybe very close to China. And if you see the cultural diversity, it is different. Like people who have visited India, they know that North India is different than South, and South is different than West, and West is different from East. There is a lot of language variation, a lot of food variation. But one thing is very, very common is how the patients are visiting to the clinic, like the FND patients. So since there is a hardly any referral pattern in FND patients, it happens that most of the patients land up to either neurologist or maybe physician sometime at tertiary at maybe small cities, a town, or maybe in the rural areas. And they are given a lot of maybe psychotropic medications also before they are actually diagnosed as FND. And one of my colleagues from South Africa, Chrisma, she was talking about the witchcraft and people visiting religious leaders. That is very common in our country. Like the moment you leave Delhi and just go surrounding the city, you will see that quacks are seeing more patients sometimes than the specialists, and patients come to us and say that we are getting very good care from the quacks, because sometimes they just give placebo and the patient is good and patient is doing well. So they feel very happy about that, because visiting a tertiary care center requires maybe some travel or maybe spending some money on investigation, but they just give placebo and the patients are all right. So they have a lot of trust in these religious leaders or quacks, whatever you can say. And that is a sad reality, because what happens that they are not given the right diagnosis, and sometimes they are loaded with some psychotropic medications, sedatives, hypnotics, and that creates more harm than good. Another specific factor is related to the age. If you see the age factors, then in the children, there is a lot of school and academic stress. And this leads to like a lot of stress on exam, lot of stress on competitive exams. And if you see the children, maybe while they are entering in class 8, class 9, and they're just preparing for their board examination and competitive examination, just before the exam, you see so many children coming to the FND clinic. And they have writing problem, they have problem in gait, sometimes they have nocturia or something like that, and they have problem in sleeping. And so it's very obvious that just before exams, the number of children landing up in FND clinics is quite more in comparison to maybe post-examination period. And sometimes they get scolding also in the schools, and maybe sometimes scolding by the parents also. That is quite prevalent in our country. And I have seen in many of the Asian countries, scolding given to the children, scolding given to the at home and maybe at school. And that also creates a lot of complexity. And maybe a type of abuse, you can say that might be leading to some functional disorder, not only in children, maybe as they are growing up, that might also be contributing to the FND in the adulthood or maybe in the elderly because of this trauma they are having because of the educational stress. Another, I will like to say, is the career and finance related stress that is very, very important in our setting. One of the reason you can say that the family is a joint family is quite prevalent here. It has some good aspects also. Elderly people have a lot of cushion because they live in a joint family and they are taken good care because of the joint family. A lot of people are there to take care of the daily needs of the elderly people. So for them it is good, but for maybe a person who is earning, so they have to maybe take care of a large family. So it happens that the family is big, but the number of people who are earning is maybe one or two. And that creates a lot of financial stress on people who are earning. And maybe we have seen many patients like that, they have FND just because they lost their job, or maybe they have taken some loans and they could not repay it. And that led to FND, and that is very, very common. Coming to the family scenario, it's very important to understand that the joint family, like I said, that at one hand, it is very beneficial for the elderly people, like people with Parkinson's disease, dementia, but people who are like young people, sometimes the joint family lead to a lot of functional disorder. And one thing is very common in females, like what happens that in our scenario, the moment females are married, they are expected to shift to their in-law's house, and there is a lot of conflict between the daughter-in-laws and mother-in-laws. And if you see the 50% females in the age group of maybe middle age group, 50 to 60% patient have this stress, like stress related to complexity of relationship with in-laws, and that is very, very common, and that is prevalent across the country. And this is very interesting and needs to be studied in maybe some prospective data, that how the family structure is leading to maybe more incidence of functional disorder in younger population, but maybe less incidence of functional disorder in elderly population. So at one hand, it has benefits, and at one hand, it has some, like you can say, precipitating factor, or maybe it might be causing some aggravating factor, you can say. The last point I will just say that many of these patients have not access to FND care, because if you see the health structure, the health structure is primarily driven by the government sector, but around 30 to 40% is the private sector, and that is very costly to afford. So most of the FND clinics are experts, movement disorder experts who are having their clinics of FND. They are at the tertiary care and they are mostly at the private centers. And government sectors hardly has any access to FND clinic. So people traveling from the rural area, people traveling from maybe lower socioeconomic status, they don't have access to the FND clinic. So I will say that not more than maybe 5 to 7% of patients, there is access to FND clinic. So these are the unique features of FND in our country.
Thank you, Sanjay. And I was very intrigued just based on our dinner conversation where you shared that same fact about just the family structure and how family structure influences FND symptom seeming prevalence. And I'd love to see studies on that. But that is such a unique cultural factor and situational factor that, again, is so unique and should be represented in conceptualizations and models and how we're thinking about this. I want to be mindful of everyone's time because, believe it or not, listeners, we've already wrapped up nearly an hour of all of these wonderful professionals' time who have taken time out of their busy day or night, depending on location on the globe. So thank you, everyone. And true to our form, we've gotten through half of what we intended to discuss. So I'm probably going to discuss with you all a follow-up to potentially talk about research aspects in each of these wonderful countries and to hear about that. But this has always just been so enlightening. And I think we really could even set an agenda for FNDS and international care just based on the issues highlighted within this podcast. And that might be something that we can all talk about going forward in our work with FNDS. So for me personally, on behalf of our listeners and FNDS, I just want to say thank you so much for taking the time. These are super important perspectives and just really appreciated to hear. So thank you.
Thank you too, Erica, to invite us. It was a great opportunity to share our experiences.
Yeah, it's a pleasure.
Yeah,
Pleasure.
it was wonderful.
Thank you very much.
Thank you.
Mine. Thank you. Physicians and providers treating functional seizures, we invite you to participate in a brief survey examining driving recommendations for patients with functional seizures. Developed by a dedicated study group, this survey seeks to capture the current opinions of physicians worldwide on this topic. Please take a moment to share your experience. A link to the 5-minute survey can be found in the show notes.